Today on Black Health Now, COVID. What about masks? And what about COVID's long-term effects? In women's health, menopause, the start of something good. Are you still trying to quit smoking? We have some helpful tips in our Taking Control segment. Living well, milk. Do you know there's more varieties than you can imagine? And Zoe, she's back, and she has some health news from a different perspective. This is Black Health Now with Dean and Doc.
Welcome to the Black Health News with Dean and Doc. With Dr. Michael Lenore and Mr. Ellis Dean, and medical experts from all over the world. And now, Mr. Ellis Dean.
A judge says we no longer have to wear masks to protect against COVID when on transportation. But public health officials say we still need them. Dr. Mike, what's the answer?
Well, I think the straight answer to that, this is a very bad decision. It's pretty clear to me, looking at all the statistics, that the COVID pandemic is not over. And we probably shouldn't change anything much. And if anything, we should be more careful. From a personal perspective, I'm not giving up my mask, and I'm much less likely to travel on airplanes or on buses where these people have the opportunity to not wear a mask and still be infected. What's probably more dangerous is the precedent that this sets. This sets the judiciary in terms of setting public health policy. And I think that is the most dangerous aspect of this. In this country, when there are pandemics, when there are epidemics, it is the public health departments that should make decisions, not judges, especially inexperienced judges, as this one seems to be.
Yeah, I think we've opened up Pandora's box just a little bit by saying you no longer have to wear it, because I don't think people are going to go back, even if that ruling gets overturned.
I kind of disagree with you on that. I think that the people who see their not masculinity, because many of them are women, who see this as a badge of honor, a badge of courage, will continue not to wear masks. And I think they'll flaunt that wherever they can. I think that there are a substantial number of Americans who disagree with this decision, but I don't think there's anything they can do about it unless the Department of Justice challenges the case and gets a positive ruling that says we need to go back. I personally am going back further. And I think everybody has to realize now, it's every person for himself and for his family. And so if you don't protect yourself and your family based upon what you know, based upon the advice of the CDC and other public health departments, you're likely to get everybody and then you're around you in trouble. I think this is a bad decision.
Well, there are someone will argue that this is what those anti-maskers were saying all along. They wanted to make it their choice whether or not to wear a mask. And so I think that's where we are until further notice that it's your choice, your personal choice, and I'm going to continue to wear my mask.
The inconsistencies are amazing. They wear seatbelts, they don't smoke. I don't see them up in arms about those two things. I think what they see in this is some way in which they can appear to be courageous, independent, and outstanding. But I think that they have accepted these kind of mandates for a number of different issues in the public health sector. This is more a political decision than it is a major decision based on any logic.
You know, outside of masks, there's another problem with COVID. Too many people have had it will suffer long term. Dr. Mike, what are the health problems these people are facing after having COVID, and what are their implications for them long term?
Well, these people are called long haulers. And whenever I have an issue like this, I like to talk with the person most experienced taking care of these patients. And that would be Dr. Michael Fogg's. He's the past president of the American College of Allergy and the advocate of Aurora Health System's chief allergy officer. One of the other things that we hear is that even though people get minor infections with these viruses, that you're starting to see a lot of long hauler disease. That means disease that occurs after you've had the viral infection. Does this occur with more serious infection? Can it occur with any infection? And what are some of the things people need to look for as an indication that they're in that particular position?
So they can be manifested by a variety of somatic symptoms, cognitive impairment symptoms, and it really is, in the minds of many, equally as serious as a COVID-19 original infection.
Okay, when you say somatic and cognitive, that even throws me off a little bit. Could you say it a different way?
Well, in the case of somatic complaints, patients have bodily complaints which didn't exist prior to COVID-19 infection. This could be aches and pains in the joints and muscles. This could be weakness or any of a variety of physical maladies which can occur after a COVID-19 infection. So historically, when we think about COVID-19 infections, we think about respiratory tract infections, where there is infection of the upper respiratory tract, as well as the lower respiratory tract. We think that the patient is home free because we saved the patient's life. Well, that's true, but that doesn't mean that while that infection was transpiring in the lungs, it didn't go to other parts of the body and cause other problems, which are now lingering.
Does it depend on the degree of the infection, or can it happen with mild COVID-19 infections?
It can happen with mild COVID-19 infections, but we tend to miss some of those patients because the infection was so mild, they didn't seek medical attention. In the case of serious infections where the patients were in the hospital or had to be bedridden at home, those have come to medical attention in a major way. And a lot of those patients are tracked, unlike many patients who have the milder infections.
Yeah, I saw an article that said that for African Americans, a lot of them got this infection before anybody kind of knew what it was. A lot of them get it now and don't validate that they had the infection. And eventually there's going to be a lot of money targeted at taking care of these long hauler problems. And say that if you don't have any validation that you had the infection, that you may not be eligible for some of the resources that are going to target those people. Can you tell by looking at antibodies in the system whether or not a person has had that infection?
Yeah, well, as you mentioned, ideally you want to be able to confirm that the infection exists at the time that it exists. And because of such a poor outroll of the testing kits, that wasn't possible in many communities, especially the African American communities, because you weren't going to go out and buy them out of your own at your own expense because they're expensive. So the other alternative, which you mentioned, is measuring the antibody titers in a person's circulation to determine what degree of what we call neutralizing antibodies are present after a natural infection. But that's rarely done in the inner city. Number one, they're not thinking about it. Number two, no one tells them about it. Number three, it's expensive. Number four, unless they're part of a study, it's probably not going to be done. And so therefore, it's not considered to be a practical approach, even though it's a highly effective approach.
So you would recommend to African Americans who think they've gotten COVID not to just kind of stay cool on it and not do anything, because obviously there's no specific treatment, but to try to document that infection.
Well, I mean, in a perfect world, what we would do would have the entire population tested for antibodies directed against COVID-19. Mm-hmm. And there are such tests that exist. It's just that they're not being used. Mm-hmm. The focus has been on antigen testing. Now, antigen testing is useful, but both you and I know that you could report to your doctor's office today, be antigen tested, and the test is negative. And by the time you leave the doctor's office and take the elevators to the first floor, you could have been infected. And so the antigen test is a real-time test, but after the real time is over, it's virtually meaningless because it tells you nothing about whether you were reinfected 5 minutes later, 5 hours later, 5 days later. That's important since many of these infections are what we call asymptomatic.
One final question for you, doctor. Have you gotten your booster?
Yes, I have. And I plan to get another one when it's time to get one. But I would say for people who have long hauler syndrome, or think that they have it, request antibody testing because it's
Okay.
available. And that's
Now,
the
you
only way you're going to really find out whether or not you've been infected.
Well, it seems like after watching that interview, it seems like COVID will always be with us in some form.
I think you're absolutely right, Ellis. I think one third of the people who get COVID infections may have something either with the brain, something with the lung, or something with the heart. Consequently, what's going to happen is a lot of people are going to be non-functional, and they will start to apply for disability. There's already talk about a pool of money being set aside to deal with the disability claims. So those of you who had COVID, you need to document that, validate that, because if you hope to be part of the process that gets disability, should you get long hauler disease, you're going to probably need that validation. Since African Americans certainly have been affected more, probably tested less, you're very likely that we're going to be in that pool and have to fight for some of these disability resources.
Let me ask you a follow-up question real quick. Do you think that people testing at home with all these free home tests, do you think that's going to reduce the number of actual documentation of COVID and the symptoms that are coming from the long haulers?
I can only say it probably will not reduce the symptoms, but it certainly will give you at least a case to make should you not be able to function as a result of having COVID. I think what scares me a little bit or concerns me a lot is the number of people I see and patients that I see who I know have had COVID but have not documented it. I think they're the ones that are going to be in trouble trying to get access to the resources. More importantly, though, I think that it's important for people to realize that just getting COVID is not sufficient to make you completely whole. You get away with 4 or 5 days because this long haul thing is nothing to kid with. And I think if you don't realize that, you may not recognize the symptoms and certainly not be able to appropriately manage those.
Yeah, I think that's a bit of my point in terms of when people are testing at home and don't have a duty to report the findings, they could test positive and continue to move on in their life. And since there's no documentation other than their home test, how can they then in turn later on apply for disability when there hasn't been sufficient documentation of them having COVID?
I think you make a good point. I think that a lot of people are going to be left out as my grandmother would say, left out in the cold. I think these home tests really tell you whether or not you have at least an obvious case of COVID infection. But if you're not documenting that, the system's not documented, and you're just going to be out of luck.
Well, that was a great discussion. Next on women's health, a change that all women can expect. But first, something for the men in our audience.
Being Black is still a risk factor for getting prostate cancer. I'm Dr. Michael Lenore, the Ethnic Health Report. From the American Cancer Society, according to statistics reported in 2022, over the last 5 years, Black men have been about twice as likely to die from prostate cancer compared to white men. Some good news. As of 2019, the prostate cancer death rates for Black men has gone down since it peaked in 1993. Improved survival rates may be due to better surgical and radiology treatments and the use of hormone therapy and early detection.
Menopause, the change. Men and women go through it, but the changes are mostly felt by women. A lot of stereotypes and myths have grown around menopause. Almost all are incorrect. Menopause does not have to be an end, but rather a beginning. Right, Dr. Mike?
There's no question, Ellis, that menopause affects women both physically and emotionally, and it affects their relationships as well. To discuss this, we have Kim Scott, a nurse practitioner, and Dr. Albert Brooks, an experienced OBGYN in the Washington hospital system.
Hi, Dr. Brooks.
Hi, Kim. How are you? Great to see you.
I'm great. Great to see you as well. I've been looking forward to this conversation with you about a topic that is very near and dear to my heart. And as I approach 49, it's becoming very apparent. We're here to talk about menopause. I am interested, along with many women who will be listening to this conversation, about actually if you could help us understand. And as an obstetrician and gynecologist, you're the best person to talk to about this. What occurs when menopause happens?
When menopause happens, the ovaries stop producing estrogen. And over a woman's life, that generally occurs between the age of 45 and 55. And most women, if they go 12 months without having their menstrual period, we consider that the menopause.
Okay. So it's when it's for a whole year, and I hear consecutively. So if you have a period at, after 8 months, then it's not menopause. It has to be a consecutive 12 months without a period.
Yeah, it has, by definition, the American College of Obstetrics and Gynecology and other governing bodies have defined it as it has to be 12 months. And the reason is if there is some bleeding that occurs in the middle of, let's say, after 8 or 9 months, we usually want to investigate that just to test to make sure that it's not something more serious than the menopause.
Okay. Thank you for that. Now, I've also read that there's about 70 different symptoms that come along with menopause or perimenopause. What would you say are some of the most common ones that your patients have shared with you?
Some of the most common ones are hot flashes and sleep disturbances and feelings of depression is a common complaint that patients have. Some women actually end up having loss of an ability to concentrate. They feel like they're out of sorts. But the number one condition that most women come in complaining of is hot flashes. And I should mention night sweats, because sometimes the hot flashes occur at night, and therefore the patient has sweats at night. And of course, the patient will tell us, I have not had my period. You told me I'm in the menopause, and now I'm having symptoms that are disturbing me at night. And the woman can't sleep through the night. She might have some weight gain, some urinary symptoms. And I have to mention vaginal dryness. That's a very common complaint of menopausal patients because their estrogen level is low, and therefore the tissues in the genitourinary area down at the bladder and the uterus and the labia and the outside of the vagina becomes dry, and it may be painful.
So the dryness, that leads into my next question. For women who are going through menopause, who have a husband or a partner, how does that affect sex?
Great question. It does affect sex because many times, because the woman is feeling dryness in the area, she is not interested necessarily in having sexual intercourse. And that can affect the marriage. And so what I have done over the years is to bring the spouse into the visit at some point with the wife's permission, and we sit down together and talk about these symptoms. And I think that goes a long way for the spouse supporting his wife going through this change in her life.
That makes sense, to include the spouse, the significant other, in understanding what the woman is going through. I could imagine that causes a lot of potential conflict. So, over the years, there have been changes in, I believe, hormonal replacement. Can you share with us what are the current recommendations for hormonal replacement, or even if that is a thing now?
Hormonal replacement has become basically the standard treatment for menopause patients who come to see their gynecologist. We usually choose patients who are relatively healthy. The menstrual period has not occurred for 12 months. They have to be under age 60. And we will usually start with a very low dose estrogen treatment for the symptoms of hot flashes and vaginal dryness. And we treat patients on average for about 5 years when we do this. We have different ways of giving the estrogen. We have estrogen pills. We have estrogen creams and estrogen gels. and vaginal inserts that have estrogen if we're just focused on the vaginal symptomatology. We have an estrogen skin patch that can be utilized. So we have a number of modalities. And when we give estrogen, if a woman still has her uterus, we usually give estrogen and progesterone as well.
Thank you.
And we do, I should mention, we do that to protect the lining of the uterus because unopposed estrogen can put a patient at risk for uterine cancer. And so we're very careful. And we've more commonly recently lowered the dosages of estrogen that we utilize to mitigate that risk of cancer.
Thank you for that, Dr. Brooks, because that was my next question, because there have been concerns of cancer causing with the hormonal replacement. So thank you. Over the years, they made some adjustments in the dosage.
One thing I want to add is that because of there are patients with a history of breast cancer or even a family history of breast cancer, that's one of the contraindications to using estrogen. And so we are careful with that part of it. Also, if a patient has cardiovascular disease, again, where it's one of the contraindications to using estrogen, and liver disease also. So you have to speak to your doctor about your medical history before he or she is going to put you on estrogen.
Okay. So what I hear you saying, women who have had breast cancer or have a family history of breast cancer or cardiovascular disease, heart disease, it would not be recommended for those women to have hormonal replacement.
Yes.
Okay. So as we close, I would like to hear from you. What is some advice you would give a woman going through menopause and that perimenopausal phase? What would you want to leave our listeners with as far as advice and going through menopause?
What I want to leave them with, and I've treated many, many women for menopausal symptoms, and what happens usually is we're able to mitigate those symptoms. We're able to improve things. And I want them to know that, and that we have tools available to us to do that. So they can actually not feel that this is never going to get better. We have even medications that we can use strictly for hot flashes. And that is one of the new developments. And we have and we used an antidepressant medication that also mitigates hot flashes, and that's really been a real win for the specialty. I also want to mention that a lot of women, when they go through the menopause and no longer have periods, they actually feel liberated. They don't have to worry about bleeding, possibly during sexual intercourse, or they feel empowered. And once they deal with the dry vagina and that kind of vulvar itching and whatnot, once that's dealt with the estrogen cream, they feel more liberated. They can have sex and use lubricants. And you can use over-the-counter lubricants and vaginal moisturizing gels and cream that will help limit some of the discomforts associated with the menopausal changes there. But I just want to make sure everybody understands it. It's not devastating, and it can be and has been in the past, but there are treatments and they work, and you have to talk to your doctor about them and step up and agree to get them. And usually you can just do a trial. You know, you don't have to say, if I start this, I'm never have to take it for the rest of my life. Again, most treatment is 5 years. And you can do a 3-month trial of various modalities. We can have you come back to the office for another visit. I've always worked with 1 or 2 nurse practitioners in my own office. So we do a lot of counseling for menopausal women, and we want to be their partners and bring them through this stage in their lives.
Thank you. So take home points is every woman is going to go through menopause. It is a natural occurring process.
Absolutely.
Embrace it. Over the years, thank God to scientists and advances in medicine, there are medications and treatments to treat hot flashes, to treat the mood swings, the dryness. So I think we can we're in a better state now than in past years. And so I thank you for your time and for your talent and for sharing with our listeners how to cope, how to deal with the process that is going to happen. But thank you for imparting with us some very valuable education. Thank you so much, Dr. Brooks.
Thank you. I really appreciate being able to give this message.
Thanks, Kim and Dr. Brooks. In a few seconds, our Taking Control segment helps you quit smoking. But first, a reminder about those COVID boosters.
Hold on now for those of you who thought you were out of the woods with 2 vaccines and a booster to protect you against COVID-19. I'm Dr. Michael Lenore with the African American Wellness Project's News Update. The first booster does a good job of preventing hospitalizations and deaths, but not so good against infections. And it's not as effective 4 to 6 months after it's given. So today, Pfizer and BioNTech have asked the Food and Drug Administration to speed up the process to give a 4th dose of the COVID-19 vaccine to Americans 65 and older. Moderna is in the process of doing the same. It might be a hard sell to get many Americans who expected to be protected by now. We want one vaccine to handle all COVID-19 infections and variants. And I believe that eventually that is going to happen. But if that's what's required now for complete protection and additional booster, I want to keep one step ahead of this virus.
According to the Centers for Disease Control, last year, smoking killed almost 500,000 Americans. African Americans have disproportionately higher rates of several smoking-related diseases, even though we tend to start smoking later in life and smoke fewer cigarettes per day than whites. Let that sink in. Why do cigarettes kill? Well, take a look at this.
We've heard it before. Tobacco products are dangerous. They cause heart disease, lung cancer, and other cancers. But what makes tobacco products so dangerous? The truth is, it all comes down to chemicals found in every stage of development. From growing the plant, to manufacturing the product, to using it. This toxic mix of chemicals harms almost every organ in the human body. And it actually starts here, with the tobacco plant itself. Nicotine naturally exists in the tobacco plant, serving as its pesticide against insects and animals. Nicotine is the chemical that causes addiction, and it's the main reason it's so hard to quit smoking once you start. It can change the way your brain works, causing you to crave more nicotine. Where tobacco is grown can affect its chemical content. Heavy metals like cadmium and lead are often found in the soil, and fertilizers usually contain nitrates that build up in the plant as it grows, and are released when the tobacco is burned. All cigarettes, even those advertised as natural, organic, or additive-free, have chemicals that could cause serious harm to your health. After a long hot summer, the tobacco plants are ready for harvest. During the curing process, chemicals called tobacco-specific nitrosamines, or TSNAs, form. These TSNAs can cause cancer of the lungs and esophagus. After curing, the leaves are shipped to the manufacturer. When making cigarettes, the manufacturer often adds chemicals to the tobacco to control moisture, enhance flavor, and mask harshness. But some of these added chemicals also cause harm. For example, manufacturers may add ammonia compounds, which change how easily nicotine can be absorbed into the body. Manufacturers also may add sugars to mask harshness. These natural and added sugars can lead to the formation of acetaldehyde, a cancer-causing chemical that can make nicotine even more addictive. When you smoke, you absorb these dangerous chemicals through your mouth and lungs. But there's one more way to add even more toxic chemicals to a cigarette. Light it. Burning the cigarette creates dangerous new chemicals that weren't present in the growing and manufacturing stages. If you smoke, or if you're exposed to secondhand smoke, you inhale carbon monoxide, which can lead to heart damage. 1,3-butadiene, which affects the reproductive system. acrolein, which can cause irreversible lung damage, benzene, which may decrease fertility, more than 70 cancer-causing chemicals, and many others. These chemicals are found in every puff of cigarette smoke, and they're known to cause disastrous health effects, such as lung disease, heart disease, and a laundry list of cancers. And to think, it all started here.
Dr. Mike, how can we avoid this? What are you saying to your patients when they're trying to quit smoking?
Well, most of my patients are adolescents that have started to smoke. So I have to really continue to talk to them about the possibility of long-term medical effects from smoking or vaping, which is another subject, but often lives in smoking. I think once you get hooked on cigarettes, it's very difficult as an adult. But I keep talking to adults by saying that if you stop, you can minimize the possibility that you increase your rates of a number of diseases, certainly the respiratory diseases, chronic obstructive lung disease, and also of lung cancer. You have to stop smoking for almost 10 years before you have the same advantages that people who don't smoke. So the sooner you stop, the better things are. However, I do recommend that people who smoke and are trying to stop get into established programs with proven records of success. Because trying to do it on your own, you just keep doing it over and over and over again. But I think where I have the most impact is in talking to young people who start by vaping and end up smoking.
I think we also have to take a really look back at how smoking became so pervasive in our society, because I know a lot of times men that went off to fight in Vietnam and other wars were given cigarettes when they were over there. And so they come back. I know my father was. And so he started smoking in Vietnam and has smoked ever since. And so I guess my question for you, Dr. Mike, is what is the impact on people that are around the smokers? Because I know secondhand smoke has become, it's almost just as dangerous as getting it firsthand.
Well, I think that there's no question. We've seen a lot of studies that show that if you're around secondhand smoke, it's almost like you're smoking yourself, especially for respiratory diseases. I know in my family, my dad smoked 2 packs of cigarettes a day. And when we counseled him on whether or not he had read all the information about smoking, he said yes. And I asked what he was going to do. He said he was going to stop reading. I mean, that's the attitude of a lot of people who've been smoking for some time. I personally feel pretty lucky. When I first went to college, I had some parliaments, had them dangled from my mouth, man, standing on the grass at Howard University, trying to be cool. But the stuff made me so sick, man, I couldn't get up for a couple of days. And so I haven't smoked since then. But I do think that stopping when you're young is the best strategy that we have. And I think secondhand smoke is critical in trying to control children with asthma or adults with asthma who are around that smoke.
Thanks, Dr. Mike. Now, a minute with Joey. Health from a millennial perspective.
Now that we've had these talks about type 2 diabetes, you understand that it can definitely be a killer, causing heart disease, blindness, loss of your limbs, and more. Hopefully, you better understand your parents now when they're telling your grandmama or your granddaddy why they can't have that cake at the cookout, or trying to figure out when the last time they checked their blood sugar was. Yeah, it might get on their nerves because they want that cake, but if their blood sugar's too high, they can't have it because that could kill them. If their blood sugar's already too high and the insulin isn't working, it can't do anything with that cake's glucose. So that blood drawing is really important because it lets you know what their blood sugar levels already are. Some people with type 2 diabetes also get insulin shots. So, depending on their situation, only doing blood draws or if they're also getting insulin shots, now you understand both perspectives. And now you can exhibit some patience and maybe assist your parents when they are dealing with the cranky grandparent who can't have the chocolate cake. The best solution is to either not have the cake present, or you can come up with an alternative to cure their sweet tooth.
Thanks, Zoe. We all know that cow's milk is still foundational for many of us, but these days there's milk from a number of other sources that is even more nutritious and healthy. Our Living Well editor, Andrea Bro, sourced it out for us.
Today we're going to talk about plant-based milk. There are milks made from nuts and grains, and even milk made from a bean. So let's talk about their nutritional value. Plant-based milk is perfect for people with slow digestive systems. Yes, they are low in protein, but they are also low in saturated fat and calories. They are lactose and cholesterol free, chock full of fiber, and provide many of their plants vitamins and minerals. Almond milk is one of the most popular. It is a low carb, low calorie, magnesium rich, controls blood sugar levels, drink. It's high in antioxidants like vitamin E, known to lower dementia risk, and a good source of healthy fats. An 8-ounce glass is 41 calories. Oat milk is a good alternative for those allergic to nuts and soy. However, it is high in carbs and calories. Its soluble fiber imparts a creamy quality and slows digestion, contributing to a feeling of fullness, which helps stabilize blood sugar levels. An 8-ounce glass is 120 calories. Cashew milk is high in vitamin E, iron, zinc, copper, phosphorus, and manganese. It is creamy and has no natural sugars, which means no blood sugar spikes. An 8-ounce glass of homemade is 71 calories. Soy milk is bean-based milk. It tastes the closest to cow's milk, but without the fat. And unlike others, it's a good source of a complete plant-based protein. Soy milk contains omega-3 fatty acids, the healthy fat our body cannot make independently. Omega-3s are known to help lower the risk of dementia and Alzheimer's. Claims that soy amplifies and increases the risk of breast cancer have been disproven. An 8-ounce glass is 80 calories. For more information on plant-based milks, check out our website at healthyhealingeats.com. Thanks for stopping by today. Take good care of yourself, and I'll see you next time on Living Well.
Thanks, Andrea. Remember, you can get more tips on healthy eating from her blog at healthyhealingeats.com. Dr. Mike, I know in your practice you see all sorts of food-based allergies, milk being one of them. How do you deal with them?
Well, milk is probably the number one allergen for certainly infants and children. They can develop allergies to milk very early on. It's really important to understand what an allergy to milk is. It means that you make a certain chemical substance which causes certain cells in the body to release chemicals resulting in some of the common things that you know about, asthma, nasal problems, but mostly chronic diarrhea in young infants. So it's always a suspicion when an infant can't take a particular formula, doesn't have with breast milk, switch to a formula, can't tolerate it, starts vomiting, then you have to suspect milk. As you get older, milk allergy becomes less of a problem and is replaced by something called lactose intolerance. One of the most things is that lactose intolerance is not an allergy. Remember, I said that when we have milk allergy, it's because we make a substance against milk. When you have lactose intolerance, that means that you lack an enzyme that breaks down milk. And so consequently, milk exists as a large molecule in the GI tract, dragging in fluid and causing abdominal pain and diarrhea. It can be very, very embarrassing. I happen to have lactose intolerance. It's probably the rule for African Americans rather than the exception. And several times I've had to rush out of a restaurant or just desperately try to get home because of the impact of milk, not only as a substance, because I don't drink milk, but in salad dressings and in certain desserts, milk lingers and hides, and you don't know it until you feel that first abdominal pain, and you know what's about to happen. But milk allergy, I think, is a very common problem, mostly for infants. How do we deal with it? We try to help people recognize that milk is the problem. We substitute other forms of milk, as Ms. Pro has mentioned, where the protein is not cow's milk. And many times that's all that solves the problem. Sometimes we have to make several substitutions. because you can not only have problems with cow's milk protein, but soy milk protein, and some people eat with almond milk, but there's still goat's milk and rice milk and a lot of the milks that you mentioned. Very common problem, but sometimes hard to recognize. But you'd always think about it when it's difficult for children to tolerate certain foods, and also for adults in certain circumstances.
Well, for those of us that are, we sat in the back of the classroom, what Dr. Mike was talking about is called bubble guts. And y'all have all had it if you're lactose intolerant. So that's the one thing. The second thing for you, Dr. Mike, is should we be drinking cow's milk? I mean, I know we're weaned on mother's milk, and cow's milk, even though it's similar, it's not the same. And so should we even be drinking cow's milk at all?
Well, I think when for infants, cow's milk is a vehicle to get other things in, calcium and vitamins and the like. But, I think milk is overrated as a food for children. I think most children can get the nutrients they need from other foods and don't necessarily need milk. Everybody does not need milk. And I'm in that group.
I'm one of them.
Well, maybe we should never eat together.
Well, as long as they got multiple stalls, we'll just keep it like that, and we're gonna keep this classic, Dr. Mike. So I'm gonna wrap up this discussion before we go completely off the rails. And say thank you, Dr. Mike, and thank you for joining us. Join us next week when, among other things, we'll show you why going to the dentist means more than just dental health. And don't forget to get the latest news from the AA Wellness Project at aawellnessproject.org, as well as BlackDoctor.org. And Dr. Mike, take us home.
I want to know why this dental work costs so much money. But I want to thank those of you who've taken the time to listen to our program. We'll be here every week with Black Health News with Dean and Doc. I want to sign off, as always, with health as your